Hi, everyone. Welcome to the Heilbrunn Department of Population and Family Health Monday seminars. The Department of Population and Family Health, as I think you all know, focuses very much on health as a human right. So our topic today sits squarely in the center of health as a human right. We're talking about global vaccine equity. We have three amazing panelists. I'll first describe our own Dr. Kayum Ahmed, who's an assistant professor here in the department. He works on ensuring equitable global access to COVID vaccines. He headed up amazing work on this at the Open Society Foundations, where he was division director in the public health program. He's taught classes on socioeconomic rights, decoloniality at Columbia Law School. He was chief executive officer of the South African Human Rights Commission. He has a PhD in education from Columbia, law degrees from the Universities of Oxford, Cape Town, and Leiden, as well as degrees in anthropology and theology. We're very lucky to have him in the department. Secondly, Yoke, Ling, Chee, who we're also incredibly grateful to have today. She's the executive director of the Third World Network. I'm sure many of you know what this is. She's a lawyer, has been active since the 90s in policy research and advocacy on the environmental, social, and economic impacts of globalization, especially in the South. She's executive director of Third World Network, which works on sustainable development issues, North and South relations. One focus area of her work is access to affordable medicines and particularly flexibilities in the WTO agreement on trade-related aspects of intellectual property rights. She coordinated the market review of the pharmaceutical sector that was conducted for the Malaysian Competition Commission. She has degrees from the University of Malaysia and from Cambridge University. And last, of course, but not least, we're very thrilled to have Achal Prabhala, the coordinator of AccessIBSA project. He's a writer, researcher, and strategic advocate for intellectual property reform and access to medicines, coordinator of AccessIBSA, a tri-continental project set up to expand access and speed up the discovery of new drugs in the developing world, specifically India, Brazil, and South Africa. He's worked for change in the legal and policy frameworks. He currently lives in Bangalore, and has been very active in the whole issue of access to treatment and manufacture of medicines for years. Because I like our students to hear a little bit about history, I'm just going to say that my own history is also as a human rights lawyer, and I worked in the early years of the HIV epidemic. I was put on the Clinton Task Force on AIDS Drug Development in 1995. And in 1995, people in the US began to get access to treatment and miraculously were coming from the brink of death. But the rest of the world, people continued to die of HIV and AIDS. And this issue that we're discussing today was very much central right at that precise moment. The developing countries were pushing through TRIPS, the TRIPS agreement, which extended long-term patents for developing countries and really put developing countries, and I use that in quotes, in a really tough spot. There were 184 signatories. I'm going to let our esteemed colleagues talk about this more, but I will say two things. One is that I was fairly overwhelmed by this kind of discussion by the pharmaceutical industry, even in 1995, that we cannot in any way play with the exclusivity or the long-term patents because it will completely impede research and development. The world will end. What we saw in the face of that was massive activism. Brazil, India, South Africa, lawsuits, and actually some successful tinkering with some of the flexibilities in TRIPS, and I'm sure as will be discussed, some work and some tinkering to center life-saving treatment health and human rights. But I think that some of those dimensions, some of those tensions continue today and are certainly front and central in the issue of vaccine equity. So I'm going to turn first to Yoke Ling to talk about what's happening on global vaccine equity. You are muted.
Okay, thank you very much, Terry. And it's a pleasure to join this discussion. So I'm going to run through these slides very quickly so that, of course, you can have this afterwards. Right. So basically, we are talking about, really a structural crisis. Even before COVID and the discussion about equity to vaccines, we've had access to affordable medicines and diagnostics and all kinds of medical devices being a real challenge. So here we're talking about 2 billion people. This is pre-COVID, already lack access to essential medicines. And 15% of the world's population consumes over 90% of the world's pharmaceuticals. So there's this huge imbalance, overconsumption, Me Too drugs, unnecessary, medication, and then you have the majority of the population of the world not having the most basic essential access. And so here we're talking about a really serious human rights issue. And fast forward to today, we see from, medical journals like the BMJ, really with titles like Profiteering from Vaccine Inequity, a Crime Against Humanity. This is the scale of what we're talking about in terms of violation. So here we see this very familiar. I mean, the figures just, are mind-boggling. How many percentage of the world's population in here we look about Uganda, 1%, the UK, 60% population is fully vaccinated. So these are nothing to be surprised about. And really, when you have BMJ talking about the rich world should be ashamed, we are talking about, the reality. This I found today, just, at least 15 million doses were scrapped in the US between March and September of this year alone, according to a CDC study. And a separate investigation found that 1 million doses were discarded in 10 states in the US over a few short months. It makes me speechless, and I think we all feel the horror of this. So when we talk about COVID-19, we're talking about, on the one hand, equitable access. On the other hand, we're talking about hoarding, vaccine apartheid, travel passports. It is really, where will it end? Yeah, and we're not only talking about vaccines, really, access to the therapeutics already, because we are talking about learning to live with this, mutations, variants. We have no idea when this really ends. Even if politically we want to comfort the world by saying that we are moving to an endemic, but honestly, we're not even there. Most of us are really in the throes of really the pandemic. So booster shots is a dream. We don't even have the first shot in many places. So we then talk about medicines because you need to treat, and diagnostics to even test, and masks and chemicals for the labs. So you're talking about a whole range of products. So I want to focus in the next slides about where intellectual property is the big bottleneck. Okay, so some examples very quickly, looking at the kind of products we need for COVID-19. Even test kits, sorry about the case study thing, it refers to something else which I'm not including here. So you had trade secrets, patents, right? And then mask alone, the 3M companies, N95 masks, had more than 200 patents alone and industrial designs in the US. Then you got therapeutics, so you got patents, trade secrets, vaccines, ventilators. Those valves can cost thousands of dollars, whereas you can do a 3D printing for $1 or $2. So, just because of that kind of monopoly. So even software to run a lot of these things, copyrighted. And artificial intelligence, we don't think about algorithms and AI, but they actually come into play in data sets, surveillance, training, and all these are covered with these types of intellectual property you see in the right-hand column. Yeah. So basically, we talk about always be on R&D, and therefore we have to have some kind of returns to the pricing. But a lot of research exists today to show that most product releases are what we call Me Too drugs. That's why you overconsume, and they are much more expensive with no additional therapeutic value, but they change the branding, they change the formulation, they change the registration in the FDAs of the world, and then they actually have more patents. It goes on and on and on. Now, in the European Union, as early as 2009, because of the crazy high prices, the Competition Commission found that originator companies were spending an average of only 17% of their turnover from prescription medicines on R&D worldwide, and about 23% are for marketing. And then there's this huge percentage called administration. I always think they mean the CEO's private jets. So when we look at the vaccines in the US and Europe, they're all publicly funded, essentially, yeah? And in the end, in the United States, you are paying 2, 3, 4 times over and over again, and it is unconscionable, let alone the rest of the world. So really the TRIPS agreement, as Terry said, is where the monopoly globalized, 20 years minimum for all processes and technology, and also, of course, trade secrets, they call them undisclosed information. And then, of course, there are some balance left, what we call flexibility. So it's not an absolute monopoly, but in practice, that's what it's become. Because every time you try to use exceptions, there's tremendous pressure from the industry, backed, unfortunately, by some of the governments that host these companies. So in the case of pharmaceuticals, I focus very quickly on this. It is not just 20 years, because if you take chemical medicines, the basic compound of the molecule, you get the first 20 years. And then you start applying for different parts of what makes one drug. And then you end up with extended. So in effect, you can have a drug like a diabetes, insulin product can go on for 30, 40, 50, 60 years by having different and little changes, and then you claim another 20 years. So all this depends on your national law. Unfortunately, the US is probably the most sort of, I don't even know what word to use. A patent lawyer from New York once told me, you can patent anything under the sun under US law if you get good scientists to work with lawyers and patent agents to craft the biggest kind of scope, right? And so, very quick example, this is a very popular, very widely used HIV drug. The brand name is Kaletra. It's a combination of 2 in 1. Look at this. This is the basic compound of one of them, started in the late 80s, runs out in 20 years. And then you've got polymorphs and other kind of different things. This is only a sample. And you apply later, you get another 20 years. The other compound, basic one, all runs out around here, 2015, 2013, but all the other different parts of the drug goes on and on and on. And so you extend it beyond 20 years. This is what a picture of one of these compounds and the different drugs. You have 1995 was the first one. 20 years later, it's supposed to expire. But then you have 805 patent families. And with all this complicated thicket of forest of patents around the drug, you end up extending another 13 or 14 years. And this is actually a very short example, right? So here we're talking about unconscionable monopolies. Quickly, in hepatitis C, there was a drug that was discovered that actually cures. If you detect early, you don't end up with liver cancer, you don't die, you don't cost the health system millions of dollars. So what happened was, this actually was a small company in the United States, in California, developed a drug, and Gilead Sciences, big pharmaceutical company, bought the company, right? Bought the company with all the pharmaceuticals, priced it for 12 weeks, 84,000 US dollars in the United States, which is about, for 12 weeks, a pill a day. So in Malaysia, we were negotiating our ministry for 2 years, and the price was brought down to about 12,000 in Malaysia. Before that, it was 72,000 to buy privately. Nobody could get treated. The Malaysian government had patents given to this company, to Gilead's stable, and the last patent expires in 2028. And they have other applications put in, and if we give them, still pending, the last one will go in 2032. We'll all be dead by then if we have hepatitis C. So what we did was, the government issued a compulsory license, which is a very important TRIPS flexibility, and we basically imported a generic from Egypt, and we cost it at about 120 for 12 weeks, as opposed to 12,000, right? Today, we have free treatment across the whole country in the public health system, which would have not been possible if we did not use the flexibility to deal with the monopoly. But each of these products, each of these flexibility is product by product, and we had so much pressure. We had visits from the United States ambassador, from the US trade representative in Washington flying over. We had pharmaceutical industry association putting so much pressure on the Malaysian government. This is only one example, right? Every time you use a flexibility in the TRIPS agreement, you get so much pressure. That is why in 2020, India and South Africa put forward in the pandemic emergency situation, let us have a temporary suspension on the implementation and enforcement of patents, trade secrets, industrial design, and copyright, all the monopoly sort of blockages for what? All these products here, because you need every one of these. And in the US, the Trump and Biden administration has used the Defense Production Act, invoked a national law, which basically is to keep all emergency users, put all of these things and raw materials first for the United States before you export. And if you can do that in one country, and India did the same when they were desperately, having to deal with a couple of the medications, and yet the whole world, is this where we want to head? Okay, so this is actually to free up and give certainty, legal certainty, so that pharmaceutical industry and some rich countries do not put pressures when we use these TRIPS flexibilities. Suspend it for at least 3 years, right? And we are still at the talking stage after more than a year, because you still have these resisting countries. The Biden administration came in and supported. We'll look at that quickly in the last slide afterwards. Meanwhile, we have already 64 co-sponsors, right? We have more than 40 supporters. The co-sponsors mean they take this very simple, and this is actually it. This is the main 2 paragraphs we're talking about. It's not something so complicated. It's needed, right? So the developed countries have actually, because of the Biden administration making that big announcement in May, and interestingly enough, it's about the Biden administration supports a waiver of intellectual property rights, not just patents, also copyright and trade secret, but only for vaccines, not for everything that we need. Meanwhile, the US is rather silent after that big announcement. And as we know, there's continuing big opposition from Pharma in the United States, and therefore the campaign and the activism in the US is absolutely crucial. Meanwhile, Japan, Norway, Canada softened their objections because of the US shift, but have not committed themselves to really the scope. Intense civil society campaigning in Australia led to September announcement by Australia to support. However, the Europeans, led by the Germans, are very, very resistant. They're offering all kinds of alternatives, distracting, go back and use, as Terry said, the TRIPS flexibilities, which are not sufficient, all right? So it's a tinkering and it's not sufficient. And as Graham Duffel says, the counter proposal from the EU is the delaying tactic. They're inviting a few developing countries to go to Brussels and try to strike a deal. So it's important. I want to end here by saying that for us around the world, this is probably historically one of the most unprecedented social mobilization around health. And you have hit the front news of newspapers. Even the business newspapers are talking about this, and we cannot pass the chance to not just solve the problem with suspending temporarily, but to rethink that the intellectual property regime is unsustainable, violates human rights for everyone, not for us only in the South, which is already inequitable, but also for those in the North. Thank you.
Thank you so much. I want to just say a couple of things. One is that we have a program within the department called Global Health Justice and Governance that kind of, in a nutshell, works on the damage the global North does, the governance damage the North does in the world. And I would certainly say that this whole TRIPS scheme is a prime example. So we did lead an effort to get the heads of the public health schools in this country and many other people to sign a letter asking the Biden administration to support the waiver. I also have noted the silence since. I also just wanted to say that for our students, compulsory licensing actually allows the government to temporarily override a patent and domestically produce patented drugs. Royalties are still paid to the patent holder. So when we talk about flexibilities, they have built-in protections for intellectual property. The last thing I'll say, so you can all think about it for our follow-up, is when I was at the Ford Foundation, when I came in 2006, there was a robust intellectual property portfolio. I supported ABIA and different groups and WHO to work with countries around flexibilities. In the course of my time there, we got a new president and he wiped out this work. So I do want to come back to, there's a very strong power imbalance here, and who's supporting our side on this. So I think that's a perfect intro to you, Kayum. So over to you.
Thank you so much, Terry, and really wonderful to be on this panel with incredible activists like Yoke, Ling and Achal, Prabhala. I want to add perhaps to what Yoke, Ling started off by offering 3 ideas to build on some of the ideas that she articulated very clearly and powerfully. And maybe I should call them 3 provocations, because they are meant to elicit some sort of debate and discussion around these very critical issues. The first provocation is that the vaccine has evolved in some ways from being a health technology that should be equitably distributed to becoming an instrument of power to decide who will live and who must die. And I offer this idea of reframing the vaccine as an instrument of power to locate this discussion about vaccine access in a broader conversation about the global health architecture and some of the failures that Yoke, Ling and yourself, Terry, alluded to. And so if we then agree that the vaccine is an instrument of power that mirrors the structural inequities built into the global health architecture, then the immediate question about the equitable distribution of vaccines must also be linked to questions about the systemic failures of global health. Chatham House developed this report in 2015, which defines the global health architecture as constituting actors working with the primary intent to improve health. And this study developed by Chatham House maps 203 global health actors, of which more than 90% are headquartered in the United States and in Europe. And so the site of global health in Euro-America speaks to a geography of power that reinforces these global hierarchies that's sort of playing out in the vaccine space. But these hierarchies are, of course, shifting because of COVID. While the World Health Organization, the WHO, is generally recognized as a primary actor in global health, the profit-driven pharma industry has in many ways displaced the WHO and has become the center of this global health system, exerting power and influence over vaccine access, but also engineering the trajectory of the pandemic itself. And this is a point that Achal has previously made in a number of pieces that he's written. So Moderna, for example, supplies its vaccine almost exclusively to wealthy nations in order to maximize profits. And even though it is the US taxpayer that funded the Moderna vaccine, it is Moderna that not only gives the shots, but also calls the shots. And so the vaccine as an instrument of power, therefore gives the entity that has control over the vaccine an immense amount of power. And so I want to introduce this notion of power in relation to the vaccine to try and locate this conversation of vaccine access in the broader global health architecture. The second provocation is that the human rights tactics employed by civil society to counter and contain the power of wealthy countries and the pharma industry have failed. Civil society has failed, and I include myself among those who have failed. And perhaps this is going to make me very unpopular with my fellow comrades on this panel, but I believe that it's important we discuss our collective failure as a movement. And the thing I haven't quite figured out is whether our failure stems from trying to replicate the tactics used during the AIDS movement, 20, 25 years ago, in a context that has radically shifted, or whether our failure stems from not having fully deployed all the tactics used during the AIDS movement because of the restrictions placed on us during COVID. And perhaps, Terry, I know you're moderating this conversation, but as someone who was intimately involved in that movement, can help us shed light on what is going wrong with civil society and our engagement in this space. But the second provocation I want to leave you with is that we have failed as civil society and that we need to do things differently. Which brings me to my third and final provocation. If the global health architecture located in Euro-America has failed to ensure equitable access to vaccines, particularly for countries in the global south, then perhaps it is time to decolonize the global health architecture. And applying a decolonial lens helps us make the connections between global health on the one hand and white supremacy, patriarchy, and capitalism on the other, which have been baked into the global health architecture. And so what does a decolonized global health architecture look like? And this is where, again, some conversation with colleagues on this panel and members of the audience would be helpful. I have some ideas that I've framed as questions, and I will leave you with this for us to perhaps discuss during the Q&A. But the first is, how can we de-link not only from the Euro-American geography of the global health architecture, but also from Western capitalist ideology that is attached to the problem of geography? And this includes questions around how do we circumvent the dominant Pharma model? How do we reinvent the IP rules that Yoke Ling spoke to? How can we begin to think about a world without Pharma? So that's sort of the first set of questions. The second is about the role of the university itself. The universities are often regarded as authorized centers of knowledge production, especially in the research and development process. We saw this with how Oxford developed a vaccine that was then put under pressure to collaborate with AstraZeneca to manufacture the vaccine. So what responsibility does the university have to ensure its R&D, which is largely publicly funded, is not sold off to the highest bidder? And I say this, of course, being located at a school of public health. I teach in a building called the Vagulos building, named after a former CEO of Merck Pharmaceuticals, in a classroom that's called the Bank of America classroom. And so I recognize the intimate connection between the university and pharma capital. And so how do we de-link the university from these structures of power that are reinforcing injustices globally? And then the third question, perhaps, and this is where I'll end, is how can we support R&D and manufacturing in the global south? Recently, there's an idea developed by the African Union through the Africa Centers for Disease Control. They've created this platform called the Partnerships for African Vaccine Manufacturing. And so one of the aims of this platform is to increase manufacturing of vaccines, including the COVID vaccine, but not limited to COVID, over the next 20 years. But what I fear is that Africa will simply import and try to replicate the profit-driven Pharma model from Euro-America. And so in addition to supporting manufacturing and R&D in the global south, a decolonial approach forces us to ask, how can we instill an African indigenous value system that centers Ubuntu, for instance, instead of capitalism, as we think about these alternatives to the global health architecture? So decoloniality is essentially about delinking from dominant systems of power. And so the question becomes, how do we dismantle while simultaneously building a new health architecture? Thanks.
Thank you so much, Kayum. So I will just quickly say before I turn this over to Achal that I think, two things. One is, again, I raised the question of donors and the power imbalance and support for people doing the work this work. And then secondly, I'll simply point out that Bill Gates has made his position against any kind of waiver well known, and Gates is one of the biggest funders of WHO. So just to say, to your point about the global architecture, we've seen this kind of intermeshing in the global architecture Of course, these issues are totally appropriate to raise around the universities, but also around the global architecture. And with that, I'll turn over to you, Achal.
Thank you, Terry. I'm so happy to be here with Yoke, Ling, and Kayum, but also you. I've admired your work stretching all the way back into the very beginning of AIDS activism. So maybe what I can do to close this out is to restate the problem again in the simplest possible form. We need to vaccinate the world. That task requires billions more vaccines than we have, and specifically more than 10 billion vaccines at the very least. Now, no company can do that alone, and no country can do that alone. What it requires is for every vaccine manufacturer around the world to make as many of these vaccines as we have in the world. But that, in turn, requires the US government and the German government in particular to dismantle a fearsome web of monopolies that companies like Moderna and Johnson & Johnson and Pfizer and BioNTech hold on their vaccines. But then this is where you might get a slightly different perspective of what's needed depending on who you're listening to, and where some of the activism that I and others around me have been engaged in slightly differs from Western and American activism in particular on how we can make this happen. This is a somewhat fine point to concentrate on, but I think it's a useful window into the world of the solutions that are on offer. And I think there are crucial and very urgent lessons that need to be taken away from what's happening. The first point of divergence, I think, is on what vaccines are useful to us in the world. Now, American activism on this has a laser sharp focus on mRNA vaccines. Now, look, I'm saying American activism, but of course, I'm talking specifically about the section of the activism that works on expanding vaccine access through things like technology transfers. Now, there are plenty of you who work on the TRIPS waiver, on other issues. I'm not necessarily talking about you. But our activism, and I say ours because I refer to activism in many poor countries, has a slightly broader focus, which is on any vaccine that works. Now, this includes vaccines from China, from Russia, and even Cuba. Now, you might well ask why, right? You might say, look, we know that mRNA vaccines have higher efficacy and they're easier to make. And you're right, they are indeed both of those things. But they are also another thing, completely, totally unavailable in India, where I live, and in a majority of countries in the world. Yoke, Ling and I, earlier in the year, in February, worked extensively on what we saw then as the promise of Chinese and Russian vaccines. Now, many things have changed since that time. The Sinovac and Sinopharm vaccines are currently, today, the most used vaccines in the world. And it turns out that the Sputnik V vaccine from Russia may work fine, but no one can actually make it since its creators didn't fully work out the right way to manufacture it. This is something we found out as recently as last month. But take the Sinovac and Sinopharm vaccines, for instance. They have low double-digit percentage less efficacy than the mRNA vaccines when it comes to protection from transmission, which is just one of the metrics you can use to measure relative efficacy. And they have an even smaller difference when it comes to protection against hospitalization and death. The same roughly holds true for the J&J vaccine, which a comedian recently described as the third most desirable vaccine in the United States, or even AstraZeneca. All of these vaccines have done their job in Brazil, Turkey, India, South Africa, or indeed vast swathes of the world, from Latin America to Asia and to the Middle East. So the choice is not mRNA vaccines or nothing. And I think it might seem like that in America, where you are, or Europe, if you're lucky enough to live there. But we have different choices. Most of the world who live in countries like I do not have the luxury of an mRNA vaccine. And you know what? Other vaccines have worked just fine. There are large studies now from Chile to South Africa to India that give us hard data that confirms so. Cuba has 2 remarkable protein subunit vaccines that are ready to go, ready to be licensed at an affordable price to absolutely any country who wants to make them. And these are vaccines that not only work very well, but are really easy to make, more so than any other vaccine from the past, barring mRNA technology. And that brings us to mRNA vaccines. Yes, Obviously, I'd want that too if we had a choice for myself, for my family, for my loved ones, for all the countries I work in, precisely for all of the advantages they bring. And we're extremely grateful to activists in America who are fighting for our access to them. But even here, however, there are small differences in how we can make mRNA technology work for the world. And so that brings us to the second point of divergence, which is on how we can make these 10 billion vaccines we need. Many of the proposals circulating in the United States right now call for the US government to build, own, and operate these vast vaccine factories that can make this massive supply. But that's not quite what we want. For me, especially living here in India, I speak to vaccine manufacturers every week, and I know, and they know that they can make these vaccines. If you live in the US today, you'll hear one phrase above all others: mRNA vaccines are hard to make, which is somewhat code for we could only make them in America and Europe. But that's just not true. They're not complex. This is the paradox of the very newest technology. Is also the very easiest. They're easier to make than any other vaccine in the history of the world. There are dozens of companies who could do that in India if only the multiple layers of monopolies, and it's a fearsome set of them, from the patents to the technology to the license to the monopolies on several parts of the supply chain, like synthesizers for something called the lipid nanoparticle, which is an integral part of the mRNA vaccine, if all of these monopolies are broken. So finally, I think we're all shaped by where we come from. I'm influenced by growing up in a country, India, that was on the Soviet side of the Cold War. And I try to keep that in check when it comes to instinctive reactions to world events and things. But I think if we put our egos aside and think rationally and expansively on how we can do this to truly work for the world, we can do this better, we can do better for us, and I think we can do better for the entire world. Thank you.
Thank you so much. I think that you've raised some very important concepts that kind of weave through things that everyone has said. I just want to say that all of these kind of big statements that are made by industry are actually, there's a total lack of transparency around kind of what it actually costs to make drugs. So there's kind of this, we all have to listen to this kind of, you know, the end of the world scenario if they're forced to be transparent. And we really haven't gotten very far on any form of transparency. And I think, Achal, you're absolutely right that the US's version is quite limited in its proposed solutions are quite limited and continue to hold up this kind of global northern monopoly. So I think there is a lot to talk about. I also do want to say that, you know, when industry folks come in and out of philanthropy, you see changes in the willingness to support this very important work. And I've seen that in the course of my career over and over again. So you saw some groups around the world that were really leading on kind of developing in-country technology, lose all their financial support because an industry person or somebody who believes in the importance of, you know, long patents steps into a role. So I, you know, we need to disentangle all of this, I think. So I do want to ask, I know we have a lot of questions, but I just want to ask your kind of put back to you the question that Kayum put to me. How can we be more strategic globally? And I say that wincing somewhat because all of the activists around the world, we see obviously a rise of right-wing governments. You saw the pandemic, you see the pandemic being exploited for right-wing agendas all the way across. So how can we be more strategic in this moment? I think, Achal, you brought up that the US people, activists in the US need to be a lot more humble, at the very least, about what needs to happen in other countries. We need to be led by folks in country, not folks in countries where the architecture all sits. So that I would toss out immediately. But I'm curious to know, and I know Kayum, you've overseen a portfolio dedicated to this work, and I know, or I can imagine, Yoke Ling, that you are in this position constantly of how do you have the resources to do the work that needs to be done. So would love your thoughts on strategy. Anyone?
I'm happy to go first just to fill a void. I think one of the turning points in a moment from 20 years ago sticks in my mind, which is when Cipla, a then small Indian pharmaceutical company, said on the front page of the Wall Street Journal, reported by Daniel Pearl, by the way, should we forget, that it was ready to supply Médecins Sans Frontières with the cocktail of antiretroviral drugs that then cost over $10,000 in the United States at a price of $350 per patient per year. It merited front page news on the Wall Street Journal, hardly a friend of the world's poor. This created, what it did, I think, is to light a fire under the pharmaceutical industry in the West. So there was an alternative, there was a viable alternative. Yes, the same questions and accusations about quality and people playing with their lives by taking substandard drugs were all thrown at Cipla and other companies who dared venture into their territory. But there was an alternative. There were other systems that countries could use to bypass Western monopolies. I think to a certain extent that has happened in the pandemic. The number of vaccines in use from China, certainly not by countries, all of whom are ideologically aligned or friends of China, but really just countries who were responding to necessity, there is some evidence of that. I think there isn't enough evidence of that. And I think that if there were vaccines that could compete with Moderna and Pfizer in particular, as there will be very soon with mRNA vaccines in development here and in Thailand, I think that what we'll see are alternatives that force Western companies to relinquish their monopolies, not because they like to, but because almost they have to in order to simply stay competitive. That, I think, is the worst case scenario, right? I think that the best case scenario as a strategy is for the United States and Europe to understand that the monopolies that are hurting other countries are in fact also hurting them. That it is a problem that the call is coming from inside the house, that there is a problem, maybe to a less extent, but nevertheless a problem that causes panic and anxiety and will involve spending a lot more money in the future. In the case of the Delta variant, for example, that they can only respond to by dismantling the monopoly system that they funded and created.
Thank you.
Maybe if I can jump in here, before this pandemic, even under the Trump administration, and I don't think his credit goes to Trump, but the fact that the highest prices for medicines across the board is in the United States. Remember that Senate committee that hauled up all the CEOs of the top pharmaceutical companies around the world, and it was a very telling, interrogation where very pointed questions on R&D, transparency of costs, how do you price and how do you justify? And the CEOs were just basically they couldn't answer the questions. I think we need more of that expose, because I think it's reached a point where even insurance companies around the world are coming up to say this is not tenable, right? So it is, if you just step one step back, is we talk about oncology drugs, cancer, diabetes, the whole health system is actually in a crisis, like deep crisis. So when Kayum talked about the global architecture, yes, I think that's one very important piece. And if we look at the global architecture, certainly TRIPS, it was only in 1995. Before 1995, when TRIPS came into effect, we had, I won't call it flexibility, we had policy choices. We could choose not to allow any patents on life-saving medicines. That was the choice that we had. And, there's nothing to say we can't go back to that choice. right? Because it has been the power that the pharmaceutical industry has is because they have been enabled. They've been enabled by some of the most powerful governments in the world. And by doing that, but if you say universities today, you can't tell the difference whether you're walking into a boardroom of a big company or into university. It didn't happen accidentally. Now, the rest of the world hasn't reached that stage yet. So I agree with what Achal was saying. So for us, I mean, the one thing that has come up very clearly for some of the poorest countries in the South, poorest, but where we still have resilient.
You froze us.
More. I mean, Africa is really, because of that, there's been a lot more now, but that cannot last forever because the pandemic rolls out. So it is, so I would say I'm a bit more optimistic than Kayum. I think that we have to find the architecture. Yes, the global health architecture is very colonial. Look at the international health regulations in the WHO. It was designed for the colonials to have quick responding, report on infectious diseases because we don't want to have the imperial center be infected, right? So we need to reform that. We need to make it equitable, not follow what the EU is trying to do, say, oh, let's have a new pandemic treaty. The system doesn't work, but the new pandemic treaty is about future pandemics and it's back to the same old. Now, the other place I think is very interesting in terms of kind of hope is competition authorities, antitrust authorities around the world are really stepping up. And they are cooperating in a way that is very, very interesting, whether it's South Africa or India or Malaysia or Europe. And they are fighting on big tech, whether it's pharmaceutical or Amazon or Google. Now we need from universities and all this, we need to find the allies, because you don't fight power and restructure. I mean, decolonizing is what we are having in our DNA in the South, right? We kept getting colonized again and again and again, but the power is actually also in our hands. Now, strategize, funding, yes, very quickly on that. You're absolutely right, Terry. The civil society, we also have this challenge because the swing in what is fundable and not fundable cannot determine what we need to do. My mentor, who passed away last year, said, we cannot not do what we need to do. Somehow we have to find a way to do it. And we do that. I don't want to sound that it's no problem, but honestly, when you have no choice, you find ways to do it. Frankly, many foundations across, the United States is now wanting to put lots of money into COVID. But you cannot in 18 to 24 months think you can undo all the last 20 years of not giving that support. Maybe this is the moment for foundations which are progressive to also, I'm not talking about Gates Foundation, to say this is to rise to the challenge. Let's do that global dismantling and decolonizing, because you also have decolonizing that needs to happen in the United States. That's where we need to have the solidarity. Then we work together and do the nitty-gritty. For me, the waiver of TRIPS is a lightning rod. It is not an end in itself. It is about ramping up capacity to manufacture. We have the capacity. If we hear one more time we don't have the capacity, I agree with Achal, we're going to go, strangle somebody. Not that I'm proposing that. Of course there is. And if we don't have the capacity, or we have less capacity, it's because we have been paralyzed for 20, 30 years. So it's time to just be liberated. And then we dismantle it step by step with law, economics, power, politics, social mobilizing. I believe we can do it.
Thank you. Kayum, anything to add?
I don't think there's anything I can add after Yoke Ling's comments. So happy to take some of the other questions, but I completely agree with both Achal and Yoke Ling.
I do want to just say one thing, which is I think in terms of massive mobilization in countries around the world, these are highly technical, very complex issues. And I saw one of the most important strategies in HIV back between 95 and 2003 was actually activists really taking the time to educate communities so that they would become activists on this, but actually explaining the components of the regimes, because this is so technical. And university students throughout the world were extremely important in all of that pressure before Doha, right? And all were extremely important on pushing for transparency that led to at least some changes. But this is why I think the foundations that did fund that work then, what was so criminal about them stopping was that all of that was lost for a time. And I totally agree with what you just said. people find a way, will find a way, but this kind of changing the topics we work on every 5 years, that the foundation world lives by. They get a new leader, you create a new strategy. On some of these long-term issues like this one, it is really destructive. And it has to be looked at. But over to the audience questions. I think one question is, I agree with decolonizing global health and shifting the power, but how is this feasible when donors are largely in the West? Let's start there, and then I'll go on to some of the others.
I'm happy to jump in with that one. And that's a really good point. Donors, and we think of Gates as probably the largest funder in the health space, who has, as you correctly pointed out, taken a particular position on the TRIPS waiver, and tends to fund organizations that are more conservative or middle of the road, rather than the Third World Network or Achal's organization AccessIBSA. And that is certainly a huge challenge within the donor world, which of course, as again Terry correctly points out, every 5 years there's a new strategy or a new president, and there's a major shift in focus. And so I want to respond to Yoke Ling's call to perhaps decolonize some of these institutions in the global north, including global funders, and what that could potentially look like. There have been huge campaigns around people like Bill Gates and other billionaires who, if they had paid their taxes to the state rather than create a donor-funded institution, the state could utilize those resources a lot more effectively than a donor. And it also gives, of course, immense power to donors to determine the trajectory of a number of these critical issues. So I think that's a radically important and critical issue that we need to focus on. The second is, and Terry, I know I'll come back to you often, because I do see you, as Achal does, as a leader in this space as well. And Terry, just a week or two ago, you were protesting outside the Supreme Court, and the role of civil disobedience in this vaccine justice space is something I feel like I've not seen enough of in the current wave of civil society activism. And I recognize that we're in the midst of a pandemic, so that perhaps restricts our ability to employ these tactics. But I remember 20 years ago sitting in a jail cell with a treatment action campaign activist in South Africa, Zaki Ahmed, and how important and powerful that kind of civil disobedience was in shifting the narrative and putting pressure on both the government and the pharmaceutical industry. So how can we deploy some of those tactics in this current moment, recognizing the challenges that we have? And then perhaps third, and I'll end with this, is Yoke Ling raised again this issue of booster shots in her initial comments. So I'm beginning to wonder, what could we do as citizens, people living in the global north, when we are offered booster shots, recognizing that less than 3% of Africans, for instance, are fully vaccinated? What responsibility do we have as individuals, particularly healthy individuals with no comorbidities, in relation to a booster shot, which could be used to at least deal with the major discrepancies in access in the global south? So these are some of the questions I guess I'm thinking through at the individual, the structural, and the systemic levels. And again, often struggle with coming up with concrete ideas on how to tackle these issues, but recognize that we need to ask some of these difficult questions. Yeah, thanks.
Thank you. I having come up as a young lawyer in the context of no treatment for HIV, then breakthrough, then people in the US get to live, people around the world die, along with really breaking down for communities the kind of what's really going on here, and really investing in really explaining, in a sense, doing technical assistance so that people understand why this is happening. That was a really important tactic, but so was civil disobedience. So I was arrested last week because the SCOTUS is about to overturn or allowed this horrible law in Texas to take effect where you can bounty hunt people who are assisting pregnant people in getting abortions. So it is a very familiar technique to me and a very powerful one. I'm not sure that the younger generation in the US knows that history. I found our students extremely open and extremely brave, and I was arrested with 7 of them. So I think we do need to think about the menu of options that we have in terms of strategy, and that will vary depending upon where you sit in the world. I do think those of us in the US should bear a particular burden of really demanding that some of this colonizing architecture be deconstructed. But I certainly think we need to really look at the range of tactics that could be used here. And I think some of them have fallen off the list in the US, frankly, which to me is inconceivable because the power of civil disobedience, history has shown us the power of civil disobedience. So maybe we need to refresh on that point. At least for those of us privileged in the US, it is something that should be on the table. So anyway, but just to also, we have a couple of questions. Do you think the vaccine resistance and US right-wing political infusion into vaccine acceptance and delivery has been part of the failure of the vaccine equity movement? Obviously, that's a kind of US-based question, but that's one. And another is kind of also public investment in R&D is needed in the North, that is subsidies for pharma. How do we promote this concept of R&D as public goods? Any thoughts on those comments, questions?
I can step in for a second, if I may. The issue of public investment in the pharmaceutical industry, which is something that, by the way, came to light during the pandemic, but has been a fact of everyday American and European existence for at least the last 30 or 40 years, especially since the 1980s, is something that several economists, by the way, and none of them necessarily flame-throwing communists either, have proposed alternatives to. The current system of having no accountability to the American taxpayer, of funneling money essentially into private hands for private gain in creating these pharmaceutical products, is not actually a very clever one. It's also not even a very efficient one in terms of people who are economists, who are even coming from it from a perspective of economics rather than public health. And so there are prize funds, there are various ways in which you can structure incentives to private players who want to develop drugs, who can benefit from having public money as the incentive to do so, just without having all of that end up in a very unuseful monopoly that harms society rather than helps it. These have been floated for a long time, but however, I think both Terry and Kayum alluded to this, the web of protection of these monopolies, of privileges that are afforded, particularly to the pharmaceutical industry over the years, is so complex, so overarching. You can see them all in the mRNA vaccine. It's just the perfect exhibit A of everything that's gone wrong with the way laws are made and the way companies can affect these laws over the benefit of citizens. And it will be hard, therefore, to dismantle because we take it as natural, but I think we should see it as what it is, which is unnatural, created only very recently by people who never had our best interests at heart.
Great. Anyone else want to add there? Yes, Ling.
I think that, it's been a big wake-up call. I mean, we still talk about vaccines here. Like, for example, right at the beginning of the pandemic last year, 2020, the Malaysian government decided that, my God, we it's not just this vaccine, but we are importing all vaccines. Are some of these so difficult to make? Because we have quite a vibrant domestic industry, but they have been really complaining for a long, long time that they just don't have the room to operate because of intellectual property constraints, right? And some of them, and we have very stringent regulatory standards for registration of drugs as well. So immediately the government started working on a vaccine roadmap. And it's a very interesting process because that roadmap looks at very much the kind of collaboration that we were familiar with back before the 90s, which is public research collaboration. We shared a lot of data, so the model that we're talking about as the alternative really was the default. The model that we're looking at today, this monopolistic, and the buying up of companies to kill competition, is a more recent phenomenon. And I think that I totally agree with you, Terry. History is something that we never pay enough attention and value to, especially policy makers, right? For them, the world is really like today. Pharma is God, you don't touch them. But I think that is actually being shifted because the way pharma is behaving, is really, I think very few policymakers and politicians today will agree that, they're untouchable. Now, how do we use this moment and not lose it? Because pharma's not sitting around waiting to be dismantled, of course not, right? That's why they are spending hundreds and hundreds of millions to block the waiver, because if that goes through, then it's a Pandora's box that will be opened up. Then the issue about technology, capacity and all that, there's already a lot of discussion. Now, Cuba has been already talking, to many countries. Vietnam has got things in the pipeline, and we have so many other areas of potential collaboration on the technology sharing, right? So I think it's not that it's not happening. People are not waiting. It's just that there's no certainty. Why would I, as a generic company or anybody, want to invest? Because there is an amount of investment that's needed. And so we need to bring government together with the local industry. But I think somebody mentioned early on, we do not also assume that all the local companies are necessarily going to be, wedded to access. Look at the way Mailman, right, Achal, right? Mailman was an Indian company. It got bought up, and now recently it's combined with Upjohn, and now it's the biggest, what is it called, Viatris or something like that. It's the biggest generic company in the world, but it's nothing more than an extension of Big Pharma. That's what it has become, right? So we need competition, we need all kinds of things. But I think there's a lot of South-South, there's a lot of regional cooperation, and there's also North-South. I mean, if a Canadian company cannot get permission, cannot get a compulsory license to manufacture needed COVID products because the government does not want to move, that Canadian company could be an ally for our companies. I think there's a lot of opportunity. And all these promises about Africa platform and going to South Africa, because Africa is so vocal on the waiver, is fill and finish. It's like, Africa is going to what? Manufacture to export back to Europe. So when you go under that very thin layer of the African hub, it's very questionable. And I think we need to break that. I think this is the moment now, whether we organize it, whether we use it, it's also a test for all of us. But I think we can bring policymakers and politicians if we work at it together. I do feel we can.
I agree with you. Before I go to one of the final questions and ask you all if you have any final thoughts, I want to share something. I was invited to participate on a COVID gender panel for the Generation Equality Forum that UN Women was doing, right? And I was the final speaker, and nobody mentioned vaccine equity. Nobody mentioned the role of the EU in blocking vaccine equity. And I did, of course, because I came up as I did. And it was tantamount to me, it was as if I had thrown a grenade. Nobody responded, nobody commented. And the woman who was moderating said, "Thank you for your speech." I would like to just suggest that any discussion about human rights in COVID has to take up this issue. We shouldn't be talking about gender or anything else without also incorporating vaccine equity. It's amazing to me how we break off pieces and this set of issues gets left and we discuss the edges. So I just wanted to throw that out as well. And does that have to do with Gates being a prominent funder in the global architecture? Does that have to do with the European Union not wanting to kind of shed light on its own position here? But, you know, I learned coming up as I did that we have to be strategic about all of this and call all of it out. And encourage our other partners in civil society who work on these other issues, maybe reducing gender-based violence, to also call these issues out, because they're completely interrelated and somehow they aren't seen as such. Just to this last, we have your point, I think this is to you, Kayum, about incorporating indigenous African values on development of vaccine manufacturing capacity was fascinating. Can you speak a little bit more on that? Is this being talked about within the AU and Africa CDC? I see you're losing your lights, but we can see you.
Apologies. Really good question. Unfortunately, it's not a prominent component of the conversations in the Africa CDC conversations that I've been a part of so far, but something that we continuously try to come back to as we begin to reimagine what this new global health architecture could look like and what role institutions like Africa CDC could play. The challenge is you have the African Union that is modeled on the European Union. You have the Africa Centers for Disease Control modeled on the US Centers for Disease Control. And so this importation of knowledge and ideas simply gets replicated even in, in the global South. And to try and find ways of then delinking becomes incredibly hard. It's so infused into the fabric of how we imagine the world to be that it's hard to imagine alternatives. And I think this is one of the major challenges that we face. And I think the role that a university such as ours can play in helping to shift the narrative, to shift the discourse around these issues by centering indigenous knowledge systems rather than simply replicating ideas and knowledge systems that have come to dominate the discourses around global health. And I think secondly, just to add to what Yoke Ling has said and what you've asked, Terry, about the question of gender in shaping these conversations. I know Yoke Ling shared this amazing group of women activists, Dawn, who've been leading Feminists for People vaccine, and how they draw on intersectionality as a framework for thinking about vaccine access. A really powerful mechanism to link and connect these intersections of marginality and how that can help to just rethink and refocus these issues. So I really want to give a shout out to Dawn and Third World Network and others who've been integral in framing the conversation as one that's deeply connected to intersectional gender justice. Thanks.
Absolutely true, and very, very hopeful work. I will renew my call to all people working in this space talking about COVID and gender to really take on the intersectionality at issue here. If we don't, nobody's going to get anywhere. We only have a few minutes left, so I want to invite the panelists if you have any last thoughts. I do like, because we have so many young people watching these discussions, for some words of hope. I think we had a few, so maybe if you have any other thoughts about, ways forward, what students can do, I'd love to hear them, and I know our audience would love to hear them.
I'm happy to go first, if I may. Yeah. One of the things that gave me a lot of hope a couple of months ago was chairing a meeting on behalf of a group of people who call themselves Progressive International. They're a coalition of progressive governments. And among the health ministers we spoke to were the health minister of Cuba, who offered these 2 vaccines that they had just developed to the world at what they called a solidarity price. And she said this with the caveat that they were only able to research those vaccines on the basis of a promise they made to their leadership that they would not divert money from the food budget. And so the solidarity price that they were offering their vaccines to the world at was to supplement that same food budget so that people in Cuba could eat. Now, there's a whole layers of geopolitics around this issue, of course, in America. But I was so impressed by the fact that this is the first time People have heard about the Cuban medical system, but it's the first time there were companies in India. There is a company in Vietnam already actually taking advantage of this. People are interested in this. I think one of the tragic side effects of the pandemic is that more and more people around the world are aware of what each of us can do for each other. This is a tremendously exciting thing. We have all of these new webs of connections across geographical lines that simply weren't drawn before the pandemic, right? They were there, we just didn't know they existed or that we could use them. And so I am hoping that there are all kinds of new lines of solidarity that we can draw in this pandemic that we just ignored or just took for granted or didn't realize existed before the pandemic. And if there's anything good that comes out of it, it is a new version of a better world.
Yes, thank you.
Perhaps I can build on that, and this idea of new lines of solidarity, I think, is absolutely fundamental. We have historically been very focused on the access to medicines world, which is a really niche, technocratic approach to thinking through this. But with the introduction of organizations, like Dawn and Third World Network, who have broadened in some ways the coalition of actors working on these access issues, to including feminists, racial justice movements, youth movements, I think this is definitely the direction we want to go. We've seen the increase and involvement of trade unions, of doctors and nurses. So this coalition, I think, is definitely broadening, and I have a huge amount of hope and optimism around the number of voices that are now being amplified as part of this movement. And then very specifically for students, there are incredible organizations like Universities Allied for Essential Medicines, UAEM, who've collaborated with the Center for Artistic Activism. They've developed campaigns such as Free the Vaccine campaign. And students have, in many ways, been at the center of the call to decolonize global health. So I think student voices in this space are critically important and influential, and want to encourage more students to absolutely take up the call to action, particularly around vaccine justice. Thanks.
Thanks. Ling, anything to add?
I just want to echo what Kayum just said. I think what is really exciting across so many front lines of decolonization, whether it's divestment from fossil fuel industries, pharmaceutical, there is a new level of momentum and energy from young people. We lost a bit of a generation in the 80s and 90s where globalization and Wall Street was really where everybody was heading to. I think with climate change and what's happening with vaccine inequities, it's really it has actually, and in a way that is not pessimistic, because I think young people feel this is our world, this is our society, and it's up to us, and I think that's really important. One of the things I would say though is that how do we then have the intergeneration? We talk about intersectionality, but it's also intergenerational, because there's so much experience. There's also so much of what we don't need to do again, and many things are not very new, but the power imbalances are at the level that we have is unprecedented. And the capture of the state, and the capture of the multilateral system. I want to see a lot more sort of renewed faith and commitment and fight to bring back multilateralism. I think we do need that. We do need that in such a way. And how do we do that? And the only way to do that is through people. So because we are talking, to a lot of young people and students, that it's about being organized. It's not just about having the passion and the anger. It's about the intellectual, integrity, and also to do the nitty-gritty, to go through tons and tons of papers and to do that rigor, and you combine that with passion, then I think we will have a chance. Thank you.
Thank you. So I will say only that I was in a jail cell for a bunch of hours with some ACT UP comrades and some very young people. And there was such an incredible dialogue that kind of touches on a lot of what you're saying. So I think the intergenerational, and of course, it wasn't a panacea. There were many mistakes made, right? So it's kind of an analysis of history that helps us be more strategic, helps us remember the menu of tools, but also helps us do it better. It has been a total honor to get to spend some time with all three of you. I know that the audience has really enjoyed it. I can see that. And I really want to thank you for all the work you do, and wish us all a lot more strategic time to kind of go forward on this kind of vaccine equity issue, but these larger issues of health as a human right. So thank you all, and really, it's been a pleasure and an honor. So thank you.
Thank you so much. Great to have been a panel with you, Kayum, and Achal, of course, as always.
So nice.
Let's continue working together.